I'm going to go through a presentation and just a little context. We have been working really for almost, I would say, the last 18 months to 2 years on looking forward and into the future and what's facing us. And we're going to have some, we've been working on some agreements that are going to be brought to you in the next few weeks, in the coming weeks of May, that you'll have to take action on. And we thought before we do that, it would be helpful to have a presentation that essentially kind of lays this up, tries to connect all of these events that have been happening on a very rapid basis over the last 18 months, and even take us back a little bit further, back even to 1995, which kind of which is where we started. This community started with this relationship between Seton and the public hospital, and the city of Austin. So I'm going to start there. I'm going to weave in some kind of the history, take us through where we are, what the sort of the confluence of events that occurred that put us on this current path that we're on, and then talk to you about what's going to be coming in the next few weeks. And I also want to weave in sort of what's happening here locally and how it relates to what's happening on the national level, because what we're doing here is not only a response to what's happening in Texas, it's really a response to what's happening at the national level as we try to reform healthcare in America. So I'm going to, who's doing my presentation for me? Because I can do a lot of things, but I'm not telepathic. I can't move that slide. And I'm really bad with the clicker. I just don't know how to use it.
You ready to go?
So yeah, let's get the show on the road. So let's talk about Safety Net Hospital Care in Travis County. And we like to say we're unique, and I think some people call us weird, but I prefer unique, so I'm going to stick with that term. But the Safety Net Healthcare delivery is unique in Travis County. And it's unique compared to other major metropolitan counties in that how it developed and how it originated and how we're leading this care delivery system today. For the last 18 years, hospital care, the Safety Net Hospital Care in this community, has been provided through a public-private partnership with the Seton Healthcare family. And that essentially, in its form, in terms of how it was created and how it's been implemented, the terms of that contract, that contractual agreement with Seton, have been very beneficial to the provision of primary care and have allowed us, both the city before us and then now as Central Health, allowed us to expand the primary care side of the ambulatory delivery system, and that's been very beneficial. But on the other side of it, the way our arrangement has worked has not been as beneficial to addressing both the care and the cost of hospital care. So we're going to talk about that imbalance and then talk about how we're trying to get ourselves in a more balanced relationship going forward. So prior to 1995, again, this goes back to our uniqueness. It was the city that built and operated the hospital, which is very unusual. Usually that's a county responsibility, and I would say in most major urban areas in Texas, it's the county that, or a district that supported the hospital. At that point in time, prior to 1995, hospital funding was a major problem. There was a debt was created of $35 million in the general fund related to the hospital, and that sort of spurred this discussion with Seton about taking over and operating what was then this Brackenridge Hospital as part of the Seton healthcare system to better support its viability into the future. Now, I do want to point out, prior to 1995, we had both the hospital and primary care. Both were parts of the city. They were in different divisions, departments, whatever you want to call them. And even though they were both within the city, there was a little bit of tension there in terms of that continued struggle or tension between how much money was going to fund which segments of the system, the hospital and the primary care system. So in 1995, the city leased the hospital to what is now known as University Medical Center Brackenridge to the Seton Healthcare family. So we had the beginnings of this public-private partnership. The City of Austin was the governmental partner, the public partner. It still maintained primary care responsibility. And at least the hospital, Brackenridge Hospital, to Seton, which is a nonprofit entity, And in that agreement, it was a very beneficial agreement for the city of Austin. And it essentially was implemented in a way that capped the city's risk, financial risk for the cost of care provided to the safety net of Travis County. But even though it was beneficial to the city in terms of capping that risk, it created an imbalance for funding for the system as a whole. And I think the way that state and federal funding evolved over time created a larger and larger imbalance over time, in that even though there were additional federal funds coming into the community that were designed to pay for uncompensated care as that burden grew, the way our financial relationship worked with the hospital essentially sent much of those dollars to us to fund primary care and fewer dollars to fund the increasing cost of the hospital care. So if you think about that, again, we were very advantaged on the governmental side. We had the ability and the funding to continue to grow primary care, which is a good thing because that's where we're headed today. But we had this imbalance because at the same time, the hospital burden was continuing to grow as our population continued to grow, and the cost of acute care was growing up as our uninsured rates continued to be very high. So let's move forward then to 2004, when the district was created. So at that point, the lease that was between the city and Seton became a lease between Central Health and Seton. It transferred to us. And essentially, the revenues that were going to the city and that financial relationship was essentially was transferred to the Central Health, and it continued to be very favorable for us over time. Again, as federal programs grew, as additional funds were coming into the community, and that helped continue to fuel our ability to fund primary care, but at the same time kept the funding pace for acute care was not as great. So the cost of acute care was growing, but the funding pace was not keeping us. So let's just to illustrate. I want to illustrate for you the kind of this very favorable revenue situation that we had under the lease. In the years when we've laid out for you, in 2005 was the first fiscal year of Central Health, so we wanted to start from there. But between 2005 and 2009, every year we budgeted essentially relatively same amount of money, anywhere between $15 to $17 million a year, to come from as additional rent from the lease arrangement with Seton. But what happened is we received much more additional rent than we expected. So each year we had additional revenues available to us. And that essentially for us, because we didn't spend it, kind of dropped to the bottom line, or if we did spend it, allowed us to continue to expand primary care. But what happened is that additional funding essentially worked to keep our tax rate lower, because we had more money than we were projected to receive. It essentially allowed us to keep our tax rate relatively level and not ask for significant increases, because our burdens were not increasing, correct? I mean, from primary care side, we were getting more money, we were funding primary care out of this relationship with Seton. However, it wasn't as favorable on the hospital side, because they were getting increased funding, but it wasn't keeping up with the costs that was being incurred by the Seton Healthcare family to care for the patients that we were responsible for. So let's talk about where we are presently, and I'm going to kind of leap to 2009 and then come up to the current day. In 2009, you remember, we moved the primary care clinics, now known as community care, out of the city and into its own not-for-profit entity. So we had kind of a three-party relationship now. We have Central Health as a governmental entity, we have Seton, the hospital system, a nonprofit partner, and then community care. And we put a little box here that says primary care network, because community care is within that, but remember, we also have other primary care providers in our network. We have other partners that we work with. But essentially, this is our relationship right now. We're the governmental entity. We have the MAP program. We pay for coverage under the MAP program. We have a network of providers that includes Seton, responsible for operation of the hospital, and our network of primary care, and I should say specialty care, that provides services to our population. And a couple things to note. Our MAP population has expanded from roughly 8,500 members per month when the district was started, and now is roughly 24,000 members per month. Now that's not, there's more than 24,000 served in a year because not everybody is in there for a whole year, so it's sometimes double that amount of total enrollees for a year. And in 2011, we have costs data that shows us from, I think, 2005 to presently what it has cost for hospital care under that MAP program. And that MAP program cost on the hospital side has grown to about $81 million a year. So there's pretty significant costs being incurred to take care of these 24,000, average 24,000 enrollees. And again,
and that's just hospital care.
That's just the hospital care. That's just the hospital care component. So we're in this environment where we still have been able to maintain a relatively stable tax rate for our community. We've been benefiting by these increases in federal funds that we participate in under the terms of the agreement. And we've been able to grow our side of the world, if you speak, the primary care, the specialty, behavioral health, et cetera, which has all been good. It's a great platform because that's where we're headed even further into the future. So let's talk about then a confluence of events. So we have the situation with Seton. We've kind of got this contractual agreement that is imbalanced in that it's very supportive of the cost and expansion of primary care, but not as supportive to the cost of the hospital side of the equation. But we have some things that are starting to happen with the national level. We have the Affordable Care Act coming into play, and we have a number of things that are being initiated at the national level that tell us the healthcare delivery system is going to change. We're going to have to do things differently. Lucky for us, we were on the right path. We had a good head start. At the state level, things were changing very significantly, and it started with legislation in 2009 where the state decided to expand managed care for Medicaid statewide. There were areas that had Medicaid managed care for years, and Travis County was one of them back, I want to say, since 95 or so. But the rest of the state did not. And out of that effort to expand Medicaid managed care statewide, which was done because it saved the state general revenue funds, it had an unintended consequence, which was to essentially, trying to think the right word, reduce the hospital's abilities, the hospitals across the state, their ability to receive these federal funds. So the federal matching funds that they'd been receiving in the past. So I'm trying to remember the number off the top of my head. I think it was about $3.2 billion. It was a big number. So the state had to come up with a solution. We couldn't take $3.2 billion out of the healthcare system in Texas and not expect that would have an extremely deleterious effect. So the state went through a process of negotiating a waiver with CMS that would reinstate this availability of federal funds and do it in a way that was compliant with the federal program requirements. And that is known as the 1115 waiver, and that was negotiated between CMS and what it did is it basically took what was existing at the time called the Upper Payment Limit Program. It folded it into this waiver program, and it added an additional pool of money that we refer to as Delivery System Reform Incentive Payments, or pool. So we now have two buckets of money under this 1115 waiver program, one that provides for care, reimbursing the cost of uncompensated care, and the other funds which provide for payment for transformational activities. So that's happening in 2009, 2010. Let's come up to 2011 in the fall, September specifically, when Senator Watson announced his 10 by 10 initiative, 10 goals in 10 years, which included the creation of a medical school at UT Austin, which we just heard a progress report from Dr. Cox. It involved building a new teaching hospital to replace an outdated and outmoded Brackenridge, but also to support expanded medical education, and a number of other goals, again, 10 and 10. So we began, with those external forces happening, we started talking about what does this mean for us locally? What should we be doing? How do we take advantage of this waiver? How do we take advantage of this change that's happening on a national level, and how do we make that work for us locally? So we began discussions in early 2012, in January and through the spring, that involved developing this concept of an integrated delivery system, like a truly integrated delivery system. And as we began to talk and as we began to understand more about how the waiver was going to work, because remember, the waiver was negotiated kind of in broad terms, and then it had to be actually planned out by the state and CMS as to how it was going to be implemented. So we were learning along the way as the state was planning this program. And we got to the point where we understood that the 1115 waiver was the key to making this 10 by 10 happen, at least the medical school, the teaching hospital, and the development of an integrated delivery system, which we determined to be the only way that we're going to try to get ahead of this cost conundrum that we face. We have not only been dealing with population increases, very significant populations in our community, and high rates of uninsured, but we also know that the way that we're delivering care is unsustainable. There's too much care taking place in the most expensive place possible, and that's the hospital. We know that we have to provide more primary and specialty care and get patients in the primary care medical home, and we have to divert from the ER and from the hospital utilization. Again, that's a national objective, and it's also a local objective. So we found, through exploration of the 1115 waiver, discussions with HHSC, that we could utilize this waiver in a way that's not being utilized anywhere else in the state of Texas. For Travis County, we asked for and did receive a favorable nod to create what we're calling the Community Care Collaborative, which is our form of an integrated delivery system. This is the way we want to deliver care to the population that we're responsible for in the community at large. And what the CCC does is, in effect, make us much more collaborative partners with Seton. We're moving from kind of a contractual relationship into a true partnership. And we are going to, on a very collaborative and cohesive go-forward basis, determine how to provide care to the community in a way that affects the cost and improves the outcomes for that. So all of that vision that we developed was memorialized in a letter of intent, which you approved and signed in April of 2012. So we're a year into this work now. It's kind of hard to believe, but here we are. It's May 1st. So 12 months later, after putting the letter of intent before us, we got to work. We continued to work with HHSC as the waiver program was developed, and we figured out how to implement it to meet our purposes. As we designed the 1115 waiver program, and as we designed the Community Care Collaborative, how it would work for us, we determined that we also did not have sufficient local funds to fund this very favorable federal matching program that would allow us to perform services, perform them to designed metrics, and if successful, pull down these additional federal funds. So this board made a decision in August of 2012 to call a vote to the community to see if they would approve an increase in our tax rate so that we would have the funds available to support this 1115 waiver program, which would result in a new way of delivering health care for our community, a much more integrated way. So luckily, the voters trusted us and said yes and approved Prop 1. And since then, we have been continuing to work to develop our plans to seek guidance from HHSC and CMS where appropriate. We have basically we've gone full bore ahead, and we've been very deliberate about taking steps to make this happen for our community, even as the programs themselves are being developed and approved. So we're kind of working hand-in-hand partners with HHSC and CMS and our local partners here to make this happen. And to some degree, a bit of, I don't want to say uncertainty, but changing environment, maybe that's the way to put it. So we have been, for the last 12 months, working on this public-private partnership. And we recognize that we had to have a different relationship to make the sustainability of both the primary care side and the acute care side of the equation work better. We know that the current funding model for, as I discussed earlier, is not sustainable from the hospital side. We can't continue to have, Seton can't continue to bear additional increasing costs of care without some way to offset those costs with additional program funds. So the letter of intent was, if you can go to the next slide, Helen. Oh, sorry. The letter of intent laid out the basic concepts of what we are trying to accomplish. And the proposed master agreement that we have been working on and will be presenting to you in the coming weeks is a document that's designed to move us from a strictly contractual relationship, which is what we have with the lease right now, that kind of lays out our obligations and Seton's obligations, to one that really reflects a true public-private partnership. And this next iteration of our public-private partnership will move our healthcare model from a collaboration that provided services more on a reactive basis and not necessarily as effective as it could be, to a well-structured integrated delivery system that provides healthcare services on a proactive basis and is designed to keep people, again, out of the ER, out of the hospital, into care in their homes and their communities. So we are, again, reflecting the national level trend, which is to move costs out of the higher cost settings and into the lower cost centers. This is our local version. I think you've probably all heard this, that all healthcare is local, and that's true. This is reflective of the players and the collaborators, the partners in our community, and how we can make this work for Travis County, and for that matter, for Central Texas. So the master agreement between Seton and Central Health formalizes that letter of intent. And just for those, I think most in the audience know, but that letter of intent has been available on our website and has been available publicly since April of last year, and it's still available. Anybody can obtain that document if they would like. But through this master agreement that we're negotiating, the parties will agree to use funds approved by the voters to maximize the federal funds that are available to us. The public-private partnership that's created by this master agreement will have 3 direct benefits to the residents of Travis County as well as Central Texas. One, we will have the creation of a medical school at UT Austin. We will have a new teaching hospital built, and we will have a much improved delivery system that we're referring to as an integrated delivery system that includes enhanced care, enhanced behavioral health, enhanced primary care, specialty care, etc. This agreement has been developed and negotiated in observance of regulatory constraints. We have a lot of rules that we have to follow. We do have a very creative model here. However, our model has to fit within a certain set of guidelines at both the federal and the state level. So we work very closely with our partners at HHSC and CMS to observe those regulatory constraints. And this agreement has to reflect our commitment to the electorate and our objective of strengthening this 18-year partnership that we have with Seton for the benefit of the community. So let's talk just a couple minutes on the medical school and teaching hospital. The new Dell Medical School at UT Austin, it does have a name and it has a significant donor funding its establishment. will be the first medical school to be built at a major research university in 35 years. And that speaks to Dr. Cox's, her statement about this is an opportunity to start new and to do it differently. So we're very, very excited about that. Seton will build a new teaching hospital and expand its graduate medical education program, which will widen the pipeline for more doctors and also other healthcare providers, as Dr. Cox mentioned, in terms of how we're going to approach the training and education of healthcare professionals. Again, this will benefit all the residents of Travis County. The creation of the Community Care Collaborative, or the CCC, is a public-private partnership. It's organized as a 501c3 nonprofit. It is between Seton Healthcare Family and Central Health, and it may have additional members over time. But within this agreement between Central Health and Seton, the parties mutually agree to manage the risk for providing safety net healthcare services. So we're bringing our resources together and we're managing that risk together, as opposed to having strict contractual relationships that obligated either party to their responsibilities. The main vehicle through which we will deliver care is the integrated healthcare delivery system known as the CCC. That's how we will provide care to the vulnerable residents of Travis County that we're responsible for. So you remember the slides we had before, it kind of took us through 2009. This is where we're going with our new model. This kind of takes us into the future, where we still have Central Health as the governmental partner. Seton as a nonprofit partner will be the members of the CCC. Our MAP program, that has been a Central Health program, will become become the responsibility of the CCC. We refer to it as MAP 2.0. It's like the next version. And through that CCC and that MAP program, we will have a network of providers, both hospital care, primary care, behavioral health care, et cetera, that will serve the patients of that CCC. So this is the model that we're working towards in the future. So what the CCC will do will help us maximize federal funds. Through the CCC, we will be able to leverage our local dollars, again, which the taxpayers approved last fall, to attract the maximum federal dollars to invest in care here in Travis County. As part of that 1115 waiver program, Seton and the CCC will carry out delivery system reform incentive payments. And those projects we're estimating have a potential combined value of about $435 million over the life of the waiver. And these projects that will be performed under this waiver are focused on transforming healthcare delivery and benefiting vulnerable Travis County residents through our integrated healthcare delivery system. So how do we make this vision happen? We are in the hopefully last stages of negotiations on finalizing the new foundational agreements that will define our new public-private relationship. And these foundational documents include the master agreement, which I've already referenced. There will be several other agreements that support that, including a services agreement. There will be a set of bylaws for the CCC, the new 501c3, that will lay out both the rights and responsibilities of each of the partners. There will be a revised lease for the existing UMCB. Seton does anticipate that there are still uses for that facility into the future, so we will negotiate an agreement with them about their continued use of that facility. And then also there will be a lease for the new teaching hospital. Central Health will control the land on which the hospital will be built, but of course we have to still work with UT about obtaining control of that land for this purpose.
And they've agreed to that.
Yes, they have agreed to that.
The details are being worked out.
Details are being worked out, and I think it's important to kind of note and also realize just how rapidly things are moving. You know, when we brought Prop 1 to the voters last fall, we didn't know where this hospital or medical school was going to be located. But once Prop 1 passed, very quickly did folks get to work and look at the land options. And now we know that this land does the hospital, can be located on UT land and on a medical campus that includes the new medical school and the buildings associated with that. So now that we know that UT is our land partner, we can work with them to and implement the appropriate agreements. So let me share with you just the components of the master agreement and what we're going to be seeing in the future when we come back to you and share that with you. We will provide details on the provisions of the master agreement, which include the governance, how budget and funding process works, because again, there are funds flowing into the CCC from several sources, the responsibilities of each of the parties, the powers that are reserved to each party, material decisions, meaning those decisions that require the parties to take action on, breaches and events of default, what happens if things don't work in the agreement like they're supposed to, and then termination and unwind provisions, what happens if the agreement does terminate and unwind. We believe that through this master agreement, we will be able to create a much stronger partnership with Seton in providing access to hospital care. And I think the best way for me to describe that is if you think about our current lease arrangement now, essentially it is a contract with that has contractual terms and has an out provision. Right now, Seton could essentially breach the agreement, I guess, if you will, could pay a $50 million payment to Central Health and be done, and not have the responsibility to provide care.
And we could too.
And we could too. $50 million seems like a lot of money. It's not a lot of money if you've got to run a hospital. So what we've moved out of that sort of simple, here we decide we don't want to be together, into something much more complex that has us at the table making decisions about the care to the community and having to work together to provide that care in a way that is maximally efficient both in quality and cost, not only for our respective entities, but for the community. So we have to accomplish this from a care delivery system reform perspective in order to make healthcare sustainable for our community into the future. So where are we now? We are in the final stages of negotiating the master agreement and the ancillary agreements that will govern how Central Health and Seton use the CCC to carry out both the waiver and the integrated delivery system objectives that we have for our vulnerable Travis County residents. I think it's fair to say that we have been unique and we're going to continue to be unique. I don't think you're going to see this agreement as you're not going to find another replicated in another part of Texas, or I'm not even sure in any other part of the country, because it truly is reflective of these parties and these partners who are sort of joined at the hip in providing care to our community. One thing I think it's interesting to think about, because we do often get compared to other districts, or people say, well, what are other districts doing, and why don't you do it like they do it? But we really are different. I'm thinking let's take a close example. Let's take Bexar County Hospital District in San Antonio, our friends down the road. In that system, the district owns the hospital, operates the primary care clinics, operates the specialty care, the behavioral health, kind of has the whole of the system under a single board of managers, right, in a single set of funding and a single set of risks. We don't have that situation here. When the city entered into this lease agreement with Seton as a nonprofit community partner, it changed that dynamic. What we're attempting to do, I shouldn't say attempting, what we are going to do with the Community Care Collaborative is we're putting ourselves back together, where we're making those decisions together that benefit the community and are the right decisions for the community, and not just for one party's benefit or lack of benefit. So we are essentially getting ourselves on the right footing to do what's right for the community and the delivery of care, to make sure we can improve the quality of care and we can get ourselves to a sustainable cost into the future. Our next steps are the master agreement and the ancillary documents will be discussed by you in our coming meetings. We had set a goal to try to accomplish this by the end of May. You will take a vote on these agreements when they're presented to you, and that's again later in the month. And we will continue to work with you and meet with you as we continue the negotiations to get these agreements finalized, so that we can present the terms of them to our community and our public here in the very near future.